Excellent. All right. Well, thank you, Eric, for that introduction, the invitation, and obviously this is always fun to work with POCUS enthusiasts. I'm just looking at the room and see how many people we have. Okay. Anyway, so let's get started. This is set up to be a 45-minute talk. I do speak a little bit faster. I have an accent. That's my major disclaimer. Obviously, if you don't understand something, please stop me. Happy to say it in Spanish and someone can translate here. And then the other thing that I'm going to do is I have to thank Eric for letting me use his slides. He was kind enough to share all the work he put into this presentation, and I really think that is fantastic. I have seen this talk he gave before, and I'm like, why would I reinvent the wheel when I've seen such a great presentation? So I want to make sure when he gets recognized for this. So thank you, Eric. So without further ado, let me see. There's no free lunch, so you guys have to answer these couple questions here, and let's see how it goes. They have 10 seconds, right, Eric? I'm just kidding. We'll give you guys a minute. When you are done, when you guys are done, please, I'm gonna look for a thumbs up and we'll keep on going. Eric, quick question. Do we review the questions now or at the end? I forgot that.
Oh, sorry about that. I muted. We actually don't. We can always.
Oh, we don't. Okay.
Oh, we can come back to it. Yeah, and review it at the end. But we haven't always.
Or at least I'll give the answers or something like that, so people don't feel like,
okay.
What was it? Okay, good deal. Should I move on? Excellent. All right, perfect. And let me see. I'm gonna click because I have 2 monitors now, so I want to make sure that things work. Okay, perfect. So nothing to disclose, as I told you guys before, and we have a little bit of an educational outline. So the number 1 point is going to be to determine POCUS application on cardiac arrest, as doing an assessment of the current available literature, both in adults and children, and also within cardiac arrest, just making sure of the importance of identifying our biggest fear, which is the cardiac standstill. And number 2 is going to be, we're going to elaborate on POCUS application during ECMO, specifically what is the role and the different things that we can already do with it. And I apologize there for the typo. So I thought this slide was really telling in that it was published in 22 in critical care research practices. And this is actually listing out all the different protocols available for the rapid shock assessment. And as you can see, there is multiple ones, and but they're all focused on adults. And from here, a lot of us have been exposed to the multiple views that derive from the complete diagnosis. And but what's the problem with this is that there's a lot of different items that are involved in these different protocols that are not really pertinent to pediatrics, such as the assessment of DVT and lung due to PE kind of thing that we will rarely see in pediatrics. Maybe at Texas Children's we see it a little more frequently than other hospitals, but and the reason I say that is because of the large catchment area, but it's one of those items that you may get prepared to it and really not too applicable for your typical practice. So what if we look at a little more evidence that tells you, and I know I don't need to sell this to anybody in this call, but there is pretty robust evidence saying that utilizing POCUS during cardiac arrest is actually helpful. So let me review this, kind of like show you the highlight of this first paper by Breitkrutz, I think that's how you say it, showing the difference between the actual diagnosis and of LV dysfunction on someone that had pulse electrical activity compared to the ones that didn't have it if they didn't use POCUS. Similarly, you have on this study, you see the difference in that patients that had a transthoracic echo to guide therapy during hypotension in a trauma bay, the management was changed in 41% of the study subjects. And similarly, in patients with septic shock in emergency departments, in a study of 73 patients, after they witnessed the ultrasound changes, therapies were changed over 50% of the times. So again, this is kind of like a general slide if you're not a POCUS believer, but all of us are. So definitely makes a difference on our management, right? What about the evidence in pediatrics? So as we know, unfortunately, as everything we do in our field is very scarce and there's very little out there. And this is one of the reports that is now getting a little bit aged now, but there's nothing really, there's not a whole lot out there that debunks this case series of 14 cases that we're able to identify standstill. And this is where this term becomes really important, because up until then, we didn't really know what to do with that data, right? So what if I put POCUS and I see some functions versus nothing? And then I'm gonna elaborate further as the talk progresses, but keep that thought in mind. So some of the recommendations of how to do echo in a cardiac arrest situation, it takes a lot of practice, right? This is not unlike some of the other assessments that we do with POCUS, this is not the time to learn type of thing. This is not the time to try to figure out how your machine works, because you only have 10 seconds to be able to assess, right? And why do I say 10 seconds? Because those are the 10 seconds that we have in between pulse checks, right? So you really don't want to get in the way of the code lead and the compressor in that give me 3 minutes, let me see exactly how it is. You just have that brief period of time. And then the other thing is that, as we know, in order to be able to optimize our image acquisition, we have to have gel on the chest. Gel is water-based, and we know anything on the chest surface that is water-based is just going to create this slippery environment, in that if you have pads in place, the pads are going to slip off. So you got to be very cognizant of what you're doing, how you're doing, wipe it off in and out, and try to get your data as fast as possible. So some recommendations that can be given for the assessment of heart function during cardiac arrest would be that the person that is going to do the scan is experienced, only uses those 10 seconds in between pulse checks, and is that data is given to the data captured from the scan is given to the code leader, not necessarily, kind of like start blurping information that may not be pertinent for the code situation. Okay. This could be a little bit of an area of controversy in terms of what's the best window to assess. And I kind of wanted to, but that's part of the reason some of the pre-talk questions were targeting to that. But to me, and everything with POCUS is, if I can get the image and answer the question that I'm scanning for, that's good enough, right? So some of the suggestions that we give you guys in this presentation is that if you have space, just because of the real estate being so small on the chest, to go subcostal and use your coronal or sagittal, your long and short axis, to be able to assess the function, that's great. Sometimes you can, if that's the case and it's a relatively bigger patient, you can just leave the probe on the chest as long as you don't interfere chest compressions, right? Also in adult patients, I personally use the apical 4-chamber view, and same thing, coronal sagittal plane, and I'll be rotating the probe, just kind of like seeing the function from that side. And I typically stay off the patient's chest when I do that, and I'm not running the code. Also, it's important to be able to, if ROSC is attained during the cardiac arrest, it's important to be able to do a second pass to see whether there's a difference in the course of that heart function after resuscitation meds were seen by the patient's tissue. And obviously, once your patient goes on to ECMO, ultrasound is instrumental. And kind of like to share some of my experiences, that every single patient that especially the most critical care patients that I'm taking care of, I just put the probe. I mean, to the point that now when the post-op patients are rolling into the unit, I just have our machine ready to go for me to just, they don't need to tell me the function. I can just see it now. It doesn't really matter what 45 minutes before the function looked like. I want to see it now. And the good thing about working in the ACHD CICU unit at TCH is that it's a relatively new unit for us, and our surgeon was hired with a little bit of a different mentality and framework, so he doesn't get offended, right? Because at the end of the day, I'm going to be taking care of the patient on behalf of the team, right? So give me 1 second. I got to make that. If you guys don't mind my phone ringing, it's too far for me to reach it, so I'm just going to keep on going. That are the typical assessment of our point of care ultrasound during cardiac arrest. And as you can see, there's a little bit of a difference between the phased array probe and the linear array probe. As we all know in this talk, we will be using phased array probe for our fast scan for the most part, and then obviously all our cardiac images. And then when it comes down to doing our lung ultrasound, for the most part, we're going to be using the linear array. And then if we're going to do a procedure, we'll be switching over to the phased array, right? So, and the H's and T's, you can easily assess right here, quick in and out, get your data and get your answer. And here we provide some examples of that. So just kind of like to illustrate what we were just talking about. And, I don't mean to disturb the talk, but here, you put a probe on someone that shows up with cardiac arrest. Say you don't have an ultrasound probe, you don't have ultrasound machine available, you can't do POCUS, vital signs are on the monitor, and you wouldn't have an idea that the function is minimal, right? Not standstill, but you can see that it's barely quivering, right? So now you put the vital signs on the screen, and the patient may have some pulsatility, but now in the back of your head, you have that the patient has very little function, and it may guide your therapy. As we saw on some of that adult evidence, that it led to changes in the management of patients in over 50% of most of those now a little bit older trials, right? So now you are doing a subcostal scan on a patient with cardiac arrest, and what is it that we see here? You can see that this is kind of like a coronal plane, and we only see myocardial contraction with, can you guys give me a second? I'm just gonna mute that here. Just give me 1 second, I'm sorry. So now we can see that the heart now is not even quivering. It's only contracting as the chest compressions are occurring. And that's actually a very important point to make, because and it's a perfect segue into the next part of the talk, which is cardiac standstill. So here I'm gonna present to you guys data from meta-analysis, systematic review meta-analysis by Blit. Again, this is now a little bit of an older paper from 2012, but there's a lot of really important information that it was news to me when I heard this talk for the first time, because I couldn't correlate the importance of cardiac standstill during cardiac arrest and the implications of it. So as you can see, it's here you have an ROC-AUC curve on the side. And then you can see that if you have cardiac standstill, the possibilities of ROSC with a sensitivity of almost 90% and an area under the curve of 0.9, that you don't have recovery of ROSC. Pretty daunting. If you translate, and the paper publishes this, and this is a good paper actually to review for you guys. If you translate that into a likelihood ratio, the positive likelihood ratio of no return to ROSC it's of 4.26. So there's 4 times more chances of not having ROSC if you have standstill during cardiac arrest. Daunting, isn't it? Super important. So now you have a second objective when you're scanning a patient. Does this patient during cardiac arrest have standstill? So then it's not just commenting, oh yeah, the function is quivering. Is there function, or if there isn't function, right? So now you put the probe, and you can totally see the difference, can you? You can see bad function on the right or decreased function versus standstill, right? Some of the major limitations from that systematic review meta-analysis were that there's no standard duration of observation. Nobody knows how long we leave the probe on the chest to be able to assess for standstill. There's no standard for the quality of imaging. Obviously, there's no standard for training, particularly in pediatrics. And there's no observational outcomes in a study in peds with ECMO. So it's hard for us to now equate, okay, standstill, no ROSC, but what if you put them on ECMO type of thing, right? So this leads to really cool areas of possible future directions in terms of what we can do, right? So now you can see what you can already think about 2 patient populations, the ones that have standstill go on ECMO, and how do the outcomes look like with the ones that go onto ECMO with no standstill, whether there's a difference or not. Maybe the outcomes are similar, and it doesn't really matter whether you have a standstill, but the evidence from that meta-analysis would say that we should have some data signal in that particular type of study. And then the other thing that is important is that, and this is kind of like a call for arms for everybody every single time that we're presenting kind of like these novel topics, is that adults are not the same as children. We can't really compare, and this should be a good fuel for us to start thinking about multi-institutional type of work to be able to systematically and similarly start storing images such that we can go back and do all these very important studies for the management of our patients. So that's cardiac arrest. Moving on to the second side of the presentation would be the application of POCUS on patients that are supported on ECMO. And again, this is a really, really good read. It was published in 2012 by this group in Melbourne. And it's really cool because it focuses on the pediatric patients and the utility of ECMO, of POCUS during ECMO. And as you can see, the list is so long, right? It should be part of an extension of your vital signs. It should be one of the items that should be listed off your daily routine, just to see whether there's, how the heart function of your patient is, specifically looking at the contractility. Is there emotion on the cannula position based on your previous imaging? In the patient that goes on to ECMO with systolic heart failure that then is led to diastolic dysfunction, whether you have LA, LV decompression, and so on and so forth, right? So let's just cover some of those very key important aspects of POCUS during ECMO. Number one is that it allows the surgeons to measure, and not actually to estimate the actual size of the cannula that they're going to place, like no other technology at the bedside, particularly for that ECPR patient, right? Sometimes when you have those elective cannulations in the OR, they have the luxury to be able to use a Heger dilator and come up with the right cannula that is the biggest size for the particular patient. But what if you don't have that? What if you crash onto ECMO? Well, if you use POCUS, you can actually use the dimension, number one. Number two, we can finally place the cannulas in the right spot. Now we have the luxury of newer technology coming through. Now we have the Protect Duo cannula that will have a little bit more of an accurate, easier to place the cannula in an accurate position with little recirculation.
Yeah.
compared to some of the previous.
Yeah.
Compared to some of the previous cannulas. But nonetheless, I have not participated on the care of any patient who gets cannulated without point of care ultrasound to make sure that the cannula is in the right spot, right? And not only for the modified Seldinger technique of putting the needle and the sequential dilation, but also to make sure that your guide wire is positioned in the right spot. So as an example here, you can see exactly where the position of your ultrasound probe is going to be, right? You go from using your linear array probe up on the neck to using your phased array cannula at the IVC or SVC RA junction to make sure that the cannula side holes are placed in a good spot. So here you have these running clips showing that, right? So we're on an adult protocol upside down, but the right structures are on the left side of the screen. And as you can see cannula position. If you do a sagittal subcostal image, you can see the SVC all along, and you can see the cannula coursing through the right atrium into the IVC. And that would be an ideal positioning for the Avalon catheter, right? Well, talking about the potential windows, there's multiple of them. As you can see, this is a personal long axis with a sweep towards the liver, where you can see the tricuspid valve through and through. You can see the LV inflow, 2 leaflets of the tricuspid valve, which is going to be your anterior and your posterior in this particular window. You don't see the septal wall, but you can see the ECMO catheter coursing through the right atrium. Now you have another patient. You are on a subcostal sagittal view. You can see the IVC, and then you can see the guide wire go through the image. In addition to that, it allowed for to see the coursing of the cannula through the venous structures. And some of the surgeons that I work with want to be able to see that cannula migrate through. So here is showing what I just talked about. And you can see that this allows you to really have the luxury of being able to say, we are on the right spot, and not having to wait for X-ray to make sure that you are in a good spot. Again, some of these utilities of ECMO, particularly for the precise positioning of the cannula, are being overcome with the Protect Duo cannula, but the Protect Duo cannula is not available for the smallest patient. So having the skill and being able to show exactly what you need to do, it's fundamental for the intensivist. So what about ECMO flows? So now you put some color Doppler signal, and then you have your segment and screen, and then you can see Doppler flow, color Doppler flows through the cannula when you are in the right spot, right? So as you know, it's going to be an opposite type of flow compared to the typical flow across the tricuspid valve. So in this particular point, you can see that the cannula position is shooting blood through the cannula into the right atrium through the tricuspid valve, right? Specifically what you're looking for. Remember, if you would have had TR, it could potentially look similar to this. So that's why it's important to be able to have the tip of your ECMO catheter showing that flow is actually being directed to the right spot. Here, a similar example, just on a different plane, you have that peristernal long sweep towards the tricuspid valve, cannula position, and then you can see some flow through the side holes, and then this patient having a little bit of TR, not related to the ECMO flow, right? What about this image? So as you can tell in this particular image, this is a linear array probe, and then you are in a sagittal plane or longitudinal, and then you can see the coursing of the catheter through and through all the way down to the hepatic portion of the IVC, and then you can see flow inside the catheter, which is exactly what you're doing while you're cannulating the patient. To get another example, because this question used to come all the time when we used to use the Avalon catheter. What's the correct location of the cannula? And for the ones that had to deal with this, it's always one of those things I really don't know. So with ultrasound now you can actually figure it out, right? The side holes that are the egress flow of the cannula have to be closer, and they are designed to be pointing at the right atrium tricuspid valve combo. So the cannula is going to end up, a portion of the cannula is actually going to end up in the infrahepatic portion of the IVC, which allows for that flow to prevent some of the recirculation. And we can talk about this when the presentation is done in a little more detail if you have any questions. And here it's another example of ECMO flows through the cannula in that same kind of like a modified peristernal long sweep towards the liver, where you can see some of that flow, unless this is the maybe Eric can tell us. This could be a little bit of arterial flow, I think, from looking at it. I don't know if Eric remembers this one.
Yeah, sorry, this is the arch. This is
Yeah, that's what I figured.
hypersternal arch. Yeah.
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 Okay. So then let's talk about this in a little more detail. And notice at the beginning, I was tempted to say it was the peristernal long, but you can see the arch being placed in, right? So when this is a very important point also when we're doing the arterial cannulation. Now you can help your surgeon point the cannula in the right direction. What is the right direction of the cannula? So if this is a peripheral cannulation and they're going through the brachiocephalic into the arch, being able to be at the junction is fundamental to prevent AI from happening. So if you have a patient with systolic and diastolic end-stage heart failure that goes on to ECMO, particularly in the form of CPR, ECPR, not having that afterload is fundamental. So being able to have the tip of the catheter right at the junction is fundamental. It's not infrequent, unfortunately, that the cannula would migrate into the ascending aorta, and then you have all that flow from your centrifugal pump opening up that aortic valve. Now you can prevent it with that. Moving forward, now you have kind of like the same image, and you can see some aliasing through the flow, and then going down. Eric, this actually looks like the right atrium as well.
Oh no, this is a little bit of a foreshortened arch, but this is the same view on the same patient, but then with the linear array so that the resolution is sharper and you've got less artifact.
Right.
So it's the same as the last one.
And then so when you, because I've never done the linear array probes, and that's the point of some of these talks for you guys, is that you're able to, the spatial resolution on this is amazing, and with only 4 centimeters. So I'm assuming this was a very small neonate when you did this scan.
Yes, this is a baby, and so that's how the linear helped with, like, you get the resolution. You don't have to penetrate too deep. Everything's pretty close to the probe. You can even see the ribs are a little bit transparent because they're so cartilagous.
Of course. And then what I really like about this image is the fact that you can see catheter tip, and you can actually tell exactly the location for them to secure the line. So the other thing that allows us to, and now going back to the phased array probe, is that what we were covering before, right? Like whether your catheter is too deep or not, whether it's at the junction, you're towards the ascending aorta, whereas your distal. And here you can see that, right? So the catheter, as the slide says it, maybe too deep. However, the X-ray sensitivity at picking up that it's just so unclear, right? So now you can guide that. Again, so that then becomes a little bit of a second skill. And some of the people on this presentation may work at a center that you're going to have someone from cardiology doing this. Now you have another tool in your toolbox to be able to help surgeons with that. So switching back to the linear array probe, and then you can see this is the same modified suprasternal modified view, and then you can actually see the tip of your ECMO cannula right at the transverse arch, and then you can see a portion of the right pulmonary artery right there, which is going to tell you that you are approaching a little bit of the ascending aorta. Okay. What about for the Protect Duo patients that we were talking about, right? So this is for the ones that are not familiar. I mean, this catheter became familiar to me only a few months ago, since we started using it for our adult patients. In the adult world, apparently this has been around for now several years, but on the pediatric side of things hasn't. But the course of the catheter is that goes typically from the neck through the SVC right atrium, RV, pulmonary valve, and PA. And as you can see, the inlet holes and the outlet holes are completely distant from each other. And as you can imagine, this guy is sucking blood out. And also it's a dual lumen catheter, and then the other lumen will deploy blood past the RV. So I kind of want to say that this may be the patient that we took care of at TCH, Eric, is it not?
Yeah, it is our adult with peripartum COVID.
That's right. I know exactly who she is. But if you look at the images here, so you can see outside the heart, you see a little bit of descending thoracic aorta. And then this is also one of those little modified views, right? So it's, again, peristernal long, sweep towards the liver. You can see the tricuspid valve, and now you can see the catheter course into the RV. And now you can see the egress of, so this is blood leaving the cannula through the inlet port. And I don't know if
MPA bifurcation.
by MPA bifurcation, that's what it was. And then I see the carrot on the side, but this is, okay, so this is what we call that Gambi view, right? So this is your peristernal short, 3 o'clock, slide up in the suprasternal region. And you end up seeing the kind of like that branching view of the PAs. And then you see a little bit of descending thoracic aorta. Perfect. So I think with multiple examples, we saw one of the biggest utilities of POCUS for during ECMO, which is cannula position. What about POCUS during ECMO run? And this leads to a point of assessing function, right? And this is going to be, you know, by virtue of the kind of support that you're using. For instance, and I just dealt with this a couple of weeks ago when I was taking care of a patient. So if you don't have an LA vent, and you're only helping out a patient, supporting a patient with peripheral ECMO, the expectation is that your patient is going to have pulsatility, right? If this is systolic heart failure that the patient went on to ECMO, say in the form of ECPR, the expectation is that there's going to be some pulsatility. What if you lose pulsatility? Well, you got lucky. You lose pulsatility, indirectly, it's going to be telling you that your myocardial contraction went down. What if you assess that function before the pulsatility is gone, and you can actually see whether there's a modification of your heart function while on ECMO? And that's exactly what you can see here. So for the patient that is cannulated peripherally in the form of ECPR, checking that myocardial systolic function and contractility is fundamental, both to tell you how the progression of the patient's course is, whether we're improving or we're not. And the other massive utility of this is whether you're developing dilated left atrium due to left atrial hypertension, whether your systolic dysfunction now is migrating into diastolic dysfunction. At Texas Children's, we have a very short window of opportunity to be able to decompress that left atrium in the peripherally cannulated patient. So if you're peripherally cannulated, what are the options to decompress the left atrium? So for the adult patient, we can use an Impella device or do left atrial septectomy. For the pediatric patient, the Impella is not available. So you can either do a septectomy with stent placement or a central conversion with an LA vent. However, if we didn't have ultrasound, we wouldn't be able to assess that. And as you can see, and what the example is trying to show you, the difference between the left atrial size in a patient who has improving myocardial function versus one that has standstill. And again, this is one of those subtle differences, and then opens up the opportunity to other items that cardiology is looking on their end, which is the LA volumetric measurements, to be able to assess by age whether we can establish if the patient has left atrial hypertension or not. But again, Texas Children's, this is a very critical point that all of us hone in on trying to establish whether we need to convert or do something to decompress the left atrium. So in other words, here you can see the patient on ECMO, and you can see a 3-window assessment of the function, and all of them kind of telling you a little bit of a different story, right? Like if you were to capture one image and you see the peristernal short axis at the level of the papillary muscles, the function would be significantly depressed, compressed in relationship to the other images that you see through. I mean, not that is, significantly better, potentially getting to trying to trial off the patient, but you have to be able to assess the function at multiple levels. Furthermore, it allows you to be able to see whether there's any shunting at any level. And as you can see, there's some spontaneous contrast, as Eric has labeled on the presentation, that are circling into your LV. Maybe not a great sign on someone who is completely septated, but something to be in mind that you can actually look into if you start getting those images. So that's utility number 2. And then utility number 3 is allowing us to prep the patient to possible decannulation. And that's all a function of what we call the winning trial, right? You put the probe, you label your different stages, and then you're going to be assessing the function as the flows go down, and you have your vasoactive support in the background supporting the patient. and see whether you can transition them out. And 100% of the times, we establish whether a patient can come off ECMO or not based on the myocardial contractility based on these POCUS images. Again, depending on the center that you work in, this may be run by cardiology, but another tool in your toolbox. So, and then just kind of like a bonus portion of the presentation is the management of different shock stages while on ECMO, right? And this is going to be predicated on the VA ECMO patient to these 4 major categories, right? Number 1, hypovolemia, short of actually exsanguinating. What are some of the other reasons of hypovolemia on an ECMO patient? B, redistribution of flow with normal myocardial performance in the form of AV valve regurgitation. And what about for the patient with VV ECMO who now develops RV systolic dysfunction? And how would that look like on the systemic side of things? And the last one would be the cannula position that we cover in a lot of detail. So in this following imaging, you see on A, it's a linear array probe, longitudinal plane. You can see your cannula position. And then in a lot of detail, Eric was able to capture that this particular patient was having IVC collapse. And I'm sure he can probably elaborate on this particular patient, assuming that he was hypovolemic and hypotensive. So this one image would allow you to resuscitate this patient accordingly. Yeah. Similarly, go ahead. Sorry.
No, sorry. Sorry about that.
No, go ahead. Go ahead, buddy.
Baby multi-organ system failure, sepsis. There was bleeding. There was a lot of third spacing going on. So you could see, like Saul was about to mention, these. There's effusion everywhere. You can see blood above the liver as well. And with that, we were hypovolemic, and the IVC was collapsed, distal to the end of the cannula.
So moving on to the next image, you can also identify that this patient has a pretty large percardial effusion. And if you have a patient on Eric, was this patient VV ECMO? You remember?
This one was VA.
VA. Okay.
This is just the venous cannula. You could part of the clue is like on the right side, there's no holes in or at least there's no obvious holes in the cannula on the right that would suggest that the Avalon.
Yeah, because you can see there you go. The ascending aorta and the aortic valve pop up as the patient is breathing in and out. And so I didn't see any cannulas there, but appropriately placed cannula. But trivia question, and we can probably elaborate that a little bit further. So if this patient was peripherally cannulated and had pulsatility, now you have a massive percardial effusion that is increasing your transmural pressure, whether you lose pulsatility or not. We can probably talk about that in a bit after we're done. So, and again, this is, what is this, Eric? It looks like is it a pleural effusion?
Sorry, yeah, that's pleural effusion around the.
Oh, but the lung consolidation. Yes. Yeah, I see it. Yeah. And then pretty impressive, right? Like, because you're not having to scan the patient, you can make all these assessments prior to your X-ray as they're coming up. So again, you look at the IVC, you've scanned so much things that are normal, and it's easy for you to pick up things that are not normal. So if you ever see a serpiginous structure in your infrahepatic IVC, beware. Shouldn't be there, right? And that's exactly what they were able to see, right? You have an echogenic structure traversing through your IVC. So, long and behold, that was a clot in the IVC. And then I don't know if Eric can share with us how this was dealt with, but at any point, all these different items that just enrich your patient management, that is at our fingertips.
Yeah.
So
post cannula came out. There's a thrombus left behind. It got systemic anticoagulation, but nothing surgical.
Excellent. So in summary, it was kind of like a little fast trip through some of the utilities of POCUS during cardiac arrest, standstill, and ECMO. Now you have a general idea of, and I'm sure you guys did, but some of the things that the way I structure some of the viewing of these patients, and it comes with experience. It comes with you actually getting exposed and being the one that right there, I'm going to have the problem. I'm going to hold it through. To me, when I saw this talk, it was key to see that now you can switch over to the linear array probe, and in the appropriately sized patient, you can actually get all kinds of images. It's important to also recognize that these are all modified windows. So again, in part, this is the beauty of being able to have a group of enthusiasts that can, we can help each other out growing and being able to understand some of these images. The things that we did not cover in a lot of details on is the utilization of spectral Doppler and color Doppler. I only talked about color Doppler during ECMO cannulation, but just to kind of guide our flow, being able to identify if the patient has pulmonary hypertension with RV hypertension, whether that flow is going to be seen on your cannulation as you're putting your V cannula. It's important for you to be able to see it. You have it available for you. The other thing that's important is that, like what I covered before, it kind of sounds silly, but water-based gel is going to impede a lot of the adhesive stuff that goes on the patient's chest, so you have to be mindful of that. Some of those therapies are life-saving, so such as the pads of the defibrillator. So make sure that your real state is relatively small. And then the final point is that ultrasound during ECMO is fundamental, right? Cardiology tends to appear at the beginning and at the end, and sometimes for the trial of ECMO, but we have the opportunity to be able to assess these patients in a longitudinal fashion. So, and I think that's pretty much it. So I do have here a little evaluation feedback form that if you guys don't mind filling out for me.